fortunate to have our colleagues from California come and join us. We've got Dr. Brenner, who is the Public Health Director at Contra Costa, and somebody who I personally just admired so much over the years when I was seeing all the great things that you guys were doing. It was very inspirational. Dr. Brenner is also the chair of the CCLHO Chronic Disease Committee. And co-chair now. And also has been the lead on a really innovative project, which is the CCLHO CHEAC leadership project, which has been another one of these great system-wide changes and really bringing together health leaders in terms of formulating intervention plans. So he's here to talk about this great work that's happening across the state, and Marianne Morgan is also with him working on his team in terms of the CCLHO CHEAC.
Yeah, Marianne and I all.
You are the team. Yeah. And also Marianne is in a really unique position here because not only is she working on the CCLHO CHEAC, but she's also now contracted with the state as they're moving forward in the CDPH Chronic Disease Coordination Plan. And if any of you, I hate to sound like this, but if any of you have been on any of those webinars,
forget that.
Sorry, everyone. Keep going. Oh. So anyway, there's a great opportunity here for us to think about that and provide recommendations that hopefully then can actually be implemented at the state level. So with that, I'd like to turn it over to Dr. Brenner.
Well, thank you, everyone. And I want to thank everybody for, if not exactly inviting me, at least allowing me to crash. You invited Marianne. I said, can I come? Can I come? This has actually been a fascinating discussion. I mean, I've just been taking notes. I've got all kinds of ideas to take back. The presentations and what's the experience here with the health department. So we got. This is going to be really good. I want to talk about the CCLHO CHEAC Chronic Disease Prevention Framework, and I guess the question we ask ourselves every spring: why is this framework different than all other frameworks? And I think one of the really unique things about this is that this is really a joint project of both the California Conference of Local Health Officers, representing the physician health officers of California, and the County Health Executives Association of California, or CHEAC, representing the public health directors. And it's a real effort for them to both work together on a key issue facing public health and all our health departments. And I think a lot of people, both in CCLHO and CHEAC, have sort of realized and appreciate that it's really appropriate for us to be working together, bringing the different skills that different representatives from both public health directors and health officers and other people involved, the chronic disease program directors involved in local health departments have to bring to bear on the issue of chronic disease, because chronic disease really is the public health issue of the 21st century. Okay? Chronic disease, the leading cause of premature death and disability, the major driver in healthcare costs, the major factor behind health inequities in our communities. Chronic disease is really it. And sort of, our public health departments in the 21st century are still heavily structured to deal with the public health issues of the late 19th century. And, so this really tries to move us in an appropriate direction. A lot of things in the chronic disease framework, and some people say, well, we know that, we know all of that, and a lot of that's true, and that's good. This framework was put together by a leadership team, the CCLHO CHEAC Chronic Disease Leadership Project leadership team. Amy's been on that, Tracy, Paul, Susan. We have a really good representation of local health departments all around the state, small, large, leadership from both CCLHO and CHEAC, and really trying to get a framework that will be useful to help promote chronic disease work in local public health throughout California. Recognizing that there's a great diversity of health departments and people function in different kinds of political and social environments, rural, conservative, liberal, and that we need to have a framework that can be useful for all the health departments in California. And I think that was one of the goals, as well as one that really moves public health in an effective direction. I think the key issue in the framework and the key focus of the framework is that, education, personal behavior change, and so on, that's important. But that without addressing the social, physical, political, environmental factors that so much influence people's behavior and the social norms, individual behavior change is very difficult to produce and even harder to sustain. And I think it's also very appropriate at the time of a lot of the healthcare reform going down and the costs of healthcare being a major issue. Our clinical colleagues are learning that too, and they really realize it. Our clinical colleagues, are facing this downpouring deluge of chronic disease in their clinics, and they really do know that unless somebody's also working upstream to deal with the social and environmental factors that are influencing this deluge of chronic disease, they're sort of left downstream dipping water with a fork, and they know it. So there's a lot of, I think, broad support for these environmental approaches. I think one of the advantages of a framework like this, a statewide framework, and as I was listening to this meeting and also thinking about Bar High and other regional groups, we're all in our local health departments. We deal with our local policymakers, our local boards of supervisors, people who wonder, what is it that you do and why are you doing it? And this builds kind of a framework and a wave of what local public health is supposed to be doing. Well, why are you doing this? Well, CCLHO, CHEAC, all the entire public health people in California, this is the approach. We're just going along with the program. And I think it helps build our ability in our local communities to do the kinds of things and push the envelopes in our local communities and with our local policymakers, however far we can push them and in whatever ways it's appropriate in our own environments. So, we passed it out, it's colorfully printed, and it's online. A couple of the things that it focuses on is really the policy and systems and organizational change as really key approaches. And it's not like the other parts of the spectrum of prevention aren't important, including individual clinical prevention, they are, but that the policy systems and organizational change and the norm change that we see in the communities is really where the bang for the buck is in a lot of ways, and that the individual education will not be effective unless it's in the context of kind of changing norm changes. And once you leave the health educator's office or the clinician's office and go back to where you've come from, where you got sick, you've got to address those issues also. Engaging communities is really important, and I think another key element of this framework is that chronic disease is so complex. And there are so many factors that are major determinants of it that local health departments by themselves are not going to be able to address it. That it involves addressing the other kinds of sectors that you're talking about, getting other agencies, government agencies, other community agencies to really see that health is part of their mission. And so, we have a little buzzword, health in all policies, but that's really what it means. And it means talking about the schools addressing health, transportations, planning departments. I heard today about how the Department of Power and Water in LA is embracing health and putting health, at least in some of its policies, the police, and really thinking about how we mobilize all the agencies in the communities and get them to think of health as part of their mission. And that makes it possible for our little public health departments to kind of take on these tasks that are so overwhelming, because we're not just our little public health departments. We can be part of all the agencies in the community. Some people are responsive to it. The police, lots of people are really responsive to understanding that, the police, we're public protection professionals. What we're trying to do is make the communities better to live in and more healthy. There's a lot of ways that can be framed. Finally, there's key priorities. You can read it: healthy nutrition, physical activity, built environment, reducing tobacco. There's a certain number of buzzwords to keep our funder happy. You'll see obesity prevention in low-income communities using social marketing. And an important issue then is the tobacco-like model. We won't get into that too much, and the role of the state. So in the tobacco-like model, it's embedded in local health departments. It works with communities. It has a dedicated funding, and there needs to be really an effective relationship with the state health department. There's problems with that, but as an ideal, that's the direction that we need to go. A role for the State Department, Health Department, technical assistance, bringing in contractors like Change Lab Solution, a California Center for Public Health Advocacy, other groups that can provide really useful technical assistance, evaluation, and an overall framework that sort of links together all our work. It's kind of like a spectrum of prevention. In Orange County, you may be doing some things on sugar-sweetened beverages. In Richmond, they may be proposing a tax, but it's all part of like a plan and a piece that fits together. And the State Health Department can be one of those groups that hold it together. And I'll stop at that because that kind of sets up Mary Ann in terms of talking to Kramer. We can open it up. I don't know how you want to use this. I'm going to stop talking. Sure.
Well, I think that we have sort of a two-part goal in this conversation, and one is having heard what you have about the framework, and some people are more familiar with it than others, to have at least a little time to talk about how do the concepts we've raised fit with the work you're doing regionally. So that's one piece, and then we'll talk about the state plan and the ways in which we're trying to integrate these two and make sure that the state is providing support to what's being done regionally. So that's really the question as you heard about the framework, and I know for me, wow, you're just all over in it. I mean, I can see lots of places where things you talked about would have relevance in terms of thinking about as you locally and regionally would try to implement some of the principles of the framework. You know, what things are coming up for you, and you already have added to my understanding about, for example, community partners and institutional partners, including Department of Agriculture. Not in here anywhere it needs to be. So, you know, the kind of question for a few minutes is just your reactions. And when you've heard people talk about these different elements, how does it apply to the work you're doing regionally? And whether it's cross-sectoral partnerships or the community partnerships, whatever it might be that really stood out for people where this is relevant to your thinking and your work. Or what's missing? What isn't in it that you say, you know, gee, for us, it's really important to think about this.
Can I have to like take some notes on a chart for you? Or?
Yes, that would be lovely. Thank you.
And we're also recording. So, well, I want to just make a couple comments. I think when the framework came out, it was the best timing in Riverside County to move this forward. I had the pleasure to participate on the local policy committee for the leadership team, and we did spend quite a bit of time looking at some best practices around reducing consumption of sugar-sweetened beverages and that whole menu of options depending on your funding or political environment, as well as looking at really focusing on safe routes to school as an opportunity to increase physical activity. But with Riverside County, all these things started coming in alignment. The framework, certainly lots of the programs that we're working on are funded to do, but also we have a new CEO who said, I want Riverside County to be the safest, most business-friendly, and best place to live in America. And then he gave us a goal to improve health and promote livable communities through partnerships, policies, service delivery systems, and initiatives. So I don't know if he was thinking about me talking, but I mean, it's just like, wow. So what we did is we did a survey of county departments to say, what are you doing around these 12 factors of a livable community? Access to healthy food, physical activity, access to health care, a safe community, all those little elements. And we got an 82% response rate from the departments, including the sheriff, who responded, of course, to our sense of place and safety. And then 92% of those who responded were doing something related to livable community. So then we convened a group to look at what's our priority, because there's so many things to do related to health in livable communities, and our group of county departments have decided of those 4 priorities that I was able to present, and they adopted, and the Board of Supervisors has now adopted through the Healthy Riverside County Initiative. It's a focus first on physical activity. So our goal is to increase by 15% the number of children, teens, adults, and older adults who meet their physical activity guideline each day. Now, we're talking about data collection. We're talking about how do you mobilize the community and not just stick with county departments, but reach out to schools, reach out to parks and rec departments and cities and things like this. So we're kind of launching this major effort. If you look on www.healthyriversidecounty.org, you'll see the framework is a document. You'll see our new 2013 community health profile that supports looking at chronic disease prevention, and then so this was just great timing. So here we've adopted these 4 priorities. As a county family, we're working together. We're going to be looking at partnerships, policies, service delivery systems, and initiatives, and it's just significant momentum right now and a lot of excitement. And we're trying to make this be something that is long-term, so it's not just a campaign. Employee wellness will be part of this. We're hoping to get some of our communities to sort of sign on to this Healthy Riverside County. It's very similar to what you're doing in LA with Choose Health LA. There's just it's kind of this movement and momentum, but we needed this framework with grounding to look at the cost benefit, so I put that in my document. We're going to start to do data collection. We're going to bring this in as part of our implementation of the Affordable Care Act in the county. So I'm hoping to really have this just be launched, and I'm really excited about it. So great timing and great work, and we'll keep you posted on how it's going.
I read it a while ago.
So did I.
I'm sure you did.
But I had an airplane.
Yeah, he had a little time.
Let me just also echo what Susan said. I think timing great, the vision great, and as I remember reading it, a lot of the language really resonated. I was looking for some examples, but there were actually nuances in the language that I thought completely resonated. The way you described health equity actually was, to me, much more embraceable than sometimes we present health equity. It turns a lot of groups off sometimes, so I really like that.
Yeah, we spend a lot of time. I mean, I think that's really important to talk about health equity in a way that ordinary people won't think you're some academic trying to show how politically correct you are.
Or a Marxist.
Yeah. Now, I may have forgotten, but a couple things that I thought maybe could have been a little bit more prominent is, how do we think about the business community?
Right.
Are they the enemy?
Right.
Can they be allies? When and how? To what degree can they be brought to the table to work cooperatively versus kind of more outsider approach going after them? I think that there could, I'm thinking in the future about how this could be tweaked. If there's a way to try to characterize that, and then. I don't remember much about the Affordable Care Act.
Nothing in there, really.
Which, to me, there are some really great, there's great potential. The fact that that hospitals, the nonprofit hospitals now have to partner, it goes beyond what our state legislation requires nonprofit hospitals to do, because it specifically says they must work with public health.
Right.
And so we're beginning to try to talk in a more structured way with the nonprofit hospitals in our county to see how we could work with them, because it could be a fair amount of money, amount of funding. The tax break that they get collectively across the nation, I read somewhere, was $13 billion. It's a lot. I don't know how much they invest. They're supposed to invest an equal amount. They probably don't. And as we've talked to them, the few we've talked to, they really are their paradigm is so different. Their view of the way they have to meet this responsibility is through delivering clinical services to the needy.
Which they have to do anyway because of IMTLA, so they get to write it off as this, and that covers it.
So So to the degree we could try to work with them, they could be a key partner. And then in addition, more recently, the San Francisco Federal Reserve has been a leader on the whole notion of community development, community investment. Yeah, and thinking about the banks, certain banks have to fulfill a requirement. I think they mentioned kind of a tax break, and in return they have to invest in community development. And I think there's some interest there on their part in working with public health. So it's another example of private sector, momentum that we could maybe capitalize on.
That's called the Community Reinvestment Act requirement?
Yes, that's it.
CRA.
Yes.
Yeah, that's a really good point. I think that those are all, kind of glaring gaps. And part of it is that in the time since when it was written and now, so much is changing. It almost needs to be updated. You kind of need an addendum. And it's part of keeping it pretty general so that it doesn't lose its applicability. But I think those pieces are really, they're going to be shaping much of what happens for the next, 10 or 20 years.
Yeah. Thank you for this. It's just an excellent document. And one of the things, I think it's related to what Paul was saying about the Affordable Care Act. That was something that jumped at me as well. But one of the things that we learned as we're engaging in Long Beach, our local hospitals, through their community benefits program, is the idea of population health. And I think in the narrative in here, it's in here, but it's not explicitly described as a population health focus on this one. So I'd just like to bring that up as a point of leveraging this conversation, how we use this document to advance it forward in our local health jurisdictions. But hospitals define and talk about population health very differently the way public health talks about it and the way other constituents talk about it. So I think the alliance and perhaps this document and some feedback that I'm going to use, that could be a conversation.
It's interesting because a lot of the hospitals sort of have the AAA view of population health, and for them the population
Or the patients.
are their patients of their hospital. Okay, that's what they mean by population health in the whole AAA approach.
Yeah, exactly.
And we refer to that in Contra Costa as the little p versus the big P. And that's the thing when you talk about population health with the clinical people, we're talking different languages. We have a different P, we have a big P, and they have a little p.
Yeah.
One of the things about the Affordable Care Act is potentially it'll start merging those two.
And that's how I see this. I see this as a tool to spark the conversation with the folks on the big P. Yeah. That's a good point.
And I think one of the things I was thinking earlier, and then as Susan talked, was this idea of how to use this document to leverage whatever we're doing and, create that kind of statewide credibility. And that part of the goal is for us all to be using the same language and, sharing the same principles and approaches and gaining that kind of credibility. So, having Riverside do that, and I think Sonoma County is doing something similar where they're pulling from this to say, well, the public health leaders in California think this is important, so it must be. And the piece about economic benefit was a big one in here for us. There's more to be said and done about that, but that people need to be able to explain what's going to be the bottom line, economic bottom line. And it's another place where business, I think, really can come to the table. So.
Got a comment?
Yeah.
So, our director sent us the final version of this, and I printed it up, read it, and then convened a group of folks from throughout the department, because I realized something Dr. Brenner said resonated with me, that our health department is set up like 19th century public health. And the focus is
you're not the only one.
So is mine.
And the language isn't evolving to keep pace with what we're trying to do here. And so part of the challenge for me has been to learn the language very quickly and to be able to communicate the issues. And so I convened a group of folks that I observed were doing some chronic disease prevention work in the department. And it was the first dialogue I think that our department's had about that.
Wow.
And so I think what we're going to do first is take an inventory of what we're doing with regard to the issue. But the challenge is really about the resources, because when I got to the end of the document, I kept asking myself, how am I going to pay for all that?
Right.
But I think there are creative ways to get at some of that. And I think what I want to do first is understand what we're internally doing, what capacity we already have. And so what I did before I convened them was I went on the web and typed in chronic disease prevention plan, and your document came up.
Ah.
Already started.
So I shared that with the group, and we're just beginning to head down that road.
Can I ask a question? I don't know if this maybe would be something for the future that I probably won't be a part of, but what counties get tobacco settlement funding and have not privatized it or in any way use it to help? Because in our county, that's the only bright spot that I can see toward moving toward the 20th century health department is that we have actually designated our tobacco settlement funding for health purposes. And even though it's all allocated and we have to pry it out of the hands of the people who have it, we have an opportunity to redirect it in some way that would get us here. And we have a potential funding stream. I don't know the degree to which other jurisdictions have that, and I also wondered if there's a similar opportunity, if it's not all done differently, to come up with some priorities for how jurisdictions direct their tobacco settlement funding, because it really is, there is a nexus to how that needs to be put forward to impact chronic disease.
Well, there's a couple of funding options. One is, we're talking about the tobacco-like model, and the key thing about the tobacco-like model is there's like a funding stream, a tobacco tax.
Mm-hmm.
So one of the things we're arguing for and advocating is that when there are these sort of health-related taxes, like a sugar-sweetened beverage tax or whatever, or more tobacco tax, that at least a portion of that money needs to be directed at chronic disease control. That's part of the tobacco-like model, and the tobacco-like model has been enormously successful.
It has been. I would add, though, one thing, though, that in the tobacco industry was enormously successful when they put the money into the general fund so that there'd be no way that could be forced to happen.
You mean on the tobacco settlement?
Correct.
Yeah, I'm talking about the cigarette tax. So but then the second thing on the tobacco settlement money, and it's one thing to get it into health, and then it's the other thing to get it into environmental upstream chronic disease prevention. Okay.
Yeah.
So that's, and when people think health, in fact, when our public thinks public health, they say, oh, you're the ones who do immunizations.
Right.
So you provide health care to the...
Yeah, and we do, and that's a good thing, but, there aren't that many deaths from vaccine-preventable diseases anymore. That's kind of like taken care of.
Yeah, I agree.
So I know there's two parts
So,
here.
yeah, so I'm going to try to segue into the next part. But I just want to say that many of the comments here for people who were at the CTG Action Institute a few weeks ago, and some of you were and others weren't, many of these kinds of conversations happened there. And one of the things you do have in your packet is a list of the recommendations that came from that institute based on some recap sessions we did around topic areas. We don't really have time to talk about it, but you'll see some of what you all have been talking about reflected there. And what made me think of it was the issue of creative use of funding, and that one thing, people came up with a lot of things for further convenings. And one of the things our project wants to look at in the coming year is regional convenings around topic areas. And one big one for people was you keep talking about grading funding and integrating into existing streams, and we don't really know what the hell that means. And we need some help thinking about that. And,
That's how we fund this whole damn project.
right, so Wendell knows. Wendell knows.
All these different funding sources, as long as they don't talk to each other, we got it covered.
Right, and you just say,
So that's where you perpetuate xylification, because that's a good thing.
when you say obesity prevention, whites on every table with your framework. So anyway, just to say that many of these issues, one of the things to do and that we'd love to do with you all, with our project, is figure out how to coordinate some of these kinds of convenings for sharing both what people are doing locally, what you all are doing regionally, how we all can be working together, because it's clear there's just not enough opportunities for that, for anybody. And there's a lot of good work going on. So that said, the second part of this is one of the goals of our project has been to not reinvent the wheel or duplicate, but rather try to get all the people who are working on all the different plans around chronic disease to actually talk to and work with each other. So we've been working very hard with the State Department of Public Health and their coordinated chronic disease prevention project, because they got CDC funding to create a chronic disease coordinating plan right about the time we were putting together our framework. And so we are really trying as much as we can to make these two documents complementary and to build on one another and to create a statewide agenda. And they're really interested in doing that, and that's why I'm going to spend 10 minutes with you here, as well as one of the
It has
things.
nothing to do with the fact that they're one of the funders.
That's one of the funders. That's how I got here. And that at the CCLHO Action Institute, one of the main things was people said the state plan needs to be aligned with the framework, and we'd really like it if people at the state would get all of their categorical programs kind of consistent with one another.
And the state people we're working with want to do that.
And they want to
We
do that.
are aligned in trying, in common goals on this.
So you just heard about the framework, which is kind of, that's the eagle. I have an analogy here. That's the eagle. That's kind of the roadmap, the banner. We want to get here. Let's all do it collectively. The state plan is a little, this is not going to work, I can tell, but I'm on a path, is like the mouse that is now saying, we need the big picture, but now we need to articulate the specifics. I know I lost it. I did it once before and it worked, but I think it was a different bird. Maybe it was a seagull. But anyway, the idea being, I'm really tired and I have to take Valium to travel, so you all are just getting me at my wrist. The idea that you have to have a big picture, and then which you all talked about earlier, and then you have to have a way to pick something concrete, but keep the big picture in mind. So you have in your packet the sort of generals of the state plan, which is still in draft form. Some of you might have attended some webinars earlier where they were attempting to get input into the plan with some limited success. But then they have asked us to actually go out and talk with people to really get more concrete feedback into this plan and how it relates to the work people are doing and what role the state can take in helping to support the work they're doing. So they basically have, if you've got this little sheet here, 4 goals. And I'm just going to go through it quickly, and I think there are a couple of goals that you're going to be most interested in. Their first goal is really around empowering communities to create physical and social environments that promote health and prevent chronic disease. So it's really about policy and building community capacity. So they have a number of strategy areas that they've prioritized: engagement of communities, helping to build sense of social connectedness, helping communities to be part of the planning and implementing of policies, working with health departments, providing people with tools and information to be able to lead healthy lives, and increasing access to the entire safe and healthy environment. So not just safe and healthy choices, but housing, employment, and education, and using proven environmental change strategies. Healthy air isn't in here. I noticed that because someone talked about climate change. So here we go. There's a piece of feedback that it's also about the air we breathe and the water we drink. So that's one goal area they have. Their second goal area is really about the health systems and the clinical connection. And it's really geared toward the hospitals, the clinics, and the public health people. And it's to really help patients, the little p, get access to and have the resources to navigate systems, to enhance coordination across healthcare delivery. So in their mind, and this would start at the state, to bring the medical, the dental, the substance abuse, and the mental health people together to really look at coordinating across programmatic areas, to look at payment mechanisms, and that's very much for them thinking about Affordable Care Act and California's own version, to reduce barriers and to maintain a skilled and diverse workforce. So that's their second big area. Their third big area is really around data and having data that is appropriate, accessible, and usable to combat chronic disease across the spectrum of prevention. So they want to get beyond just looking at high blood pressure and cholesterol and looking at the parts of the spectrum that are about policies and organizational change. And this is a lot of what you all were talking about in thinking about things like procurement and looking at the growers and the transporters, et cetera, really getting beyond are people eating healthier and are the systems more accessible and healthy? And to really inventory the various data systems that exist for chronic disease prevention and for risk factors and identify where the gaps are and help figure out with local health departments what additional data is needed and how to access it. And I was thinking about what people were saying about the getting the agriculture data and getting some of the non-health system data that the state should be able to have a convening role in. And I think
the healthy community indicator.
And
that shouldn't have to be negotiating on a case-by-case basis.
Exactly.
If we can work with BOE to get some data.
Exactly.
It should be, at the state level, it should be.
So there it is, input through the state.
That they can, in the same way local health departments can help our communities access the institutions and the resources because we know those people and have the relationships, the state has to help the local health department in that way. So they see that as a role and they're interested in hearing how they can help facilitate your work. They really want to expand their web-based ability. They want to be able to make the data very localized, very relevant at the county and the district and whatever level, and then have a statewide perspective as well, so that little examples of successes and activities, and then what's the statewide movement. And then they're really interested in promoting electronic exchange of information, which is, I think, back a bit more to healthcare and health systems. And then they have a fourth goal area that's new, and it's, I don't think, very well thought out. But basically, to me, what stands out about Invest in Wellness is the idea of sustainable funding. And I think that's where things like ACA and other systems changes really have to come to bear. So these are the four goal areas they want to work on. They want to work with local health departments. They want to know what's already going on and how can they support that. And to me, you're doing so much around policy and goal one, and you are also doing a lot around data and thinking about how to capture and describe the communities now and what needs to change for the communities to be healthier and to be able to demonstrate that change. So we don't have a lot of time, and I know it's the end of the day and everybody's probably a little burned out, but if you have thoughts about where here you're already working or need support locally or regionally, that's what I want to hear about and to be able to take back to them. Yes.
Just one example that really resonates, goal 3. We're struggling to get data from the California Department of Education, the California Physical Fitness Testing data.
Right.
It's vital. It's, I think, one of the reasons we did so well in getting federal grants is we have phenomenal data showing the trends.
The fitness data?
Fitness grant data, and it's getting harder and harder and harder to get it from them. Why couldn't the state health department work with them so that we get all access? That's just one example.
Yeah,
And then
that's great.
Another way of kind of looking at these categories is you have, and thinking about the Institute of Medicine's future public health, assessment, policy development, assurance. And I see assessment on here, front and center, and policy development. development area center. I'm not sure if this captures the assurance function. Maybe it does in goal area 2.
Assurance, say, you mean like the,
What role do we have in terms of chronic disease management, assuring that, or are we overreaching? I mean, maybe there are healthcare systems that are already poised to handle this. I know New York City, for example, we've talked a lot with them about their chronic disease work, and they have, Tom Frieden said this, they continue to say this, they've said, do not cede the clinical, don't give up. I mean, that's an important part of public health's work as well. Making sure that whatever you decide the highest priority, perhaps clinical preventive services are, or chronic disease management services, that you really focus on those. They created that hemoglobin A1C surveillance system, I think, in part to engage providers, something like that.
Don't cede the clinical chronic disease management to the clinicians.
Right.
Yeah. Although they're getting better and better at it, and in many ways, they know a lot more than we do about a lot of those things.
So maybe we're overreaching. It's a question.
good, that's interesting. What about for other people? Anything else particularly relevant in terms of your regional work?
I think this is a real opportunity for us to say, we went around to everybody in the state, just like you asked us to, and this is what they want you to do.
Right.
So, this is vague enough, their plan right now, that it covers anything you want, and we can go back and say, yeah, this is what people want from the state. And we got it like data, facilitate with the data. That's for sure.
I would.
Go ahead. I'm sorry, I just wanted to make note, I think some of the comments that were made earlier about individual-based focus, individual education, we're still looking at the individual patient, and I think the whole systems change and infrastructure change, which was so successful, some of the other tobacco and other related, that's where I'd like to see more of an emphasis. That's where I think we're behind in how we're organized, and we're behind in how our own staff look at things.
Yes.
So for me, that is the biggest factor I'd like to see emphasized.
That's good, and that's really what we try to emphasize in the chronic disease framework, because so much of what we do, and our staff do, is individual care or services and education, not to knock it. But yeah.
And the other thing I heard somebody talk about, there's been expressed a big need for a kind of strategic communication plan and messaging, and that the state could provide some leadership in that, in terms of helping to develop it and in terms of promoting it. And somebody talked about framing, might have been Lindsay, kind of helping people frame for the political context, and that is there a way the state can kind of weigh in and leverage to help, set a certain standard that is an expectation, and then help create much like tobacco did. There was a lot of very consistent messaging, some of which had to come from the state, with input from local health departments. But and that is not really here.
But that's so important, especially with Affordable Care Act. Right. So even in our little jurisdiction, we have a messaging team on the ACA that covers public health, social services, mental health. We're working together using the same language. What do we call things? Yes. And this is such an opportune time. You talked about timing with those other things. I'd love to see that.
Yeah, I think that would be really good.
And I think part of that communication plan should really articulate the return on investment of prevention.
Yeah.
That's the language that elected officials understand. That's the language that the business community understands. And in public health, we're not very good at articulating.
Is there a part in the state plan that links in more with the health and our policies, strategic work council piece? And something that I've often thought is, so you've got that part, kind of state-to-state department communication, but I'd really like to start seeing kind of the 2.0 part of it to go into state to local, and then having that cooperation as
So
a
the
more
state
local
could do a lot to help promote the concept of health in all policies on into the state of California.
Yeah, exactly, and through their departments at their local level.
Yeah.
Because I kind of feel like
That would
almost
be
that's
great.
siloed sometimes too.
Oh, yeah.
So, and then there's the new Office of Health Equity. I'm not sure how much they're working, I mean, maybe they are with the chronic disease group, but I know,
I don't
think
know,
they're all kind of
I don't
separate.
know,
Separate and silent.
I don't know if there's anybody in that office. Oh, equity.
disappointed?
Did they appoint someone?
Somebody just
I mean, there was a twinkle in someone's eye for a long time, so there might be a person there now, but.
There's somebody in charge of it. 'Cause
Oh, there is,
Well,
okay.
We
that's
got
good.
some announcement through
Yeah,
CCLHO
there's something about
a little while ago. That-
Yes, that would be great to link in with them.
You know, we were talking about this earlier, Mary Ann, before we started the meeting today about the workforce. And
Yes.
I'm looking here at the maintain skilled, cross-trained, and diverse workforce, and the whole MPH versus MA versus just generic health educators, and the whole Affordable Care Act and what that means for allied professionals, and so
Yeah.
some sort of definition for public health departments.
Oh.
I'm not grasping. What?
Well,
You had to be part of the conversation to
Okay.
know we're building on something. Go ahead.
Okay.
Right, well, we were talking about the whole concept of the formal MPH program, MPH degree, and then the CHEAC and the MCHES that's accompanied with it, that was developed to certify health educators, and the fact that in our public health departments, in my public health department, for example, we have maybe a handful of MPHs, but a whole slew of health educators that call themselves health educators, that are in the community, they're experienced, they're promoting, they're navigating, they're promoting, and the whole concept of how do we not undermine the MPH degree and maintain the integrity of that formal education, but at the same time give kudos and I'm not sure really.
But I couldn't tell whether you thought it was good or bad that there were a lot of health educators
Because we're
that didn't
mixed.
have MPH.
It's a mix. It's a mix. You know, it's a constant concern of mine to try to help our staff that isn't formally educated to train and educate and build. But I'm just doing it in my little silo. It needs to be a little bit broader, especially as we move into Affordable Care Act, and we want to make sure that they're prepared to deliver the message. And you know, I'm kind of rambling.
BTA, like a TA function, technical assistance function?
Sort of. I think there needs to be some discussion on that, because I see it here and I see it everywhere, but I'm not sure what they mean by maintain a skilled, diverse workforce. What does that mean?
What is their role? What do we want them to do?
I have a quick comment.
Yeah.
So maybe I'm just wishy,
Wish on.
but could we consider suggesting that not just sustainable funding, but sustainable, flexible funding?
Oh, nice.
Because our hands are tied many of the times. We have to get very creative to be able to maximize resources, and a lot of that gets challenged by the strings that come with all that funding.
Flexible, streamlined, there's lots of ways it could be made less cumbersome. Yeah. Great.
Also, talking about investing in wellness, I would love to see kind of a strategic plan that brings multiple actors together so that they can figure out what parts of this they can take on. So it could be ACA, it could be community benefit, Federal Reserve, local health department, private equity. Like, how do we come together from a funding level and figure out how do we work together in investing in certain communities and advancing them? And I don't think we've done that from a funding perspective to strategically start thinking about that from multiple avenues.
Well, it makes me think that one other thing, if we had more time, which we don't, that we've been talking with the state about is that they want to have a statewide meeting in January to kind of continue this dialogue. And one of their thoughts, which was actually pretty good, was to bring not just the health departments together, but the other key partners from around the state to really say, if we're going to do this work, none of us can do it by ourselves. The state can do some things, the local health departments can do others, but what are other people able to do, and how do we commit to work together? And that, you know, that is sort of a next level conversation. We have to kind of know what we're all doing ourselves, and then we move out. And so I think that would we can reinforce with them the value of that and their ability to convene such a discussion of the stakeholders, and, you know, I think that's really good to add here.
Is the time with our
I think, yeah.
I think we're pretty much
sad. I
We've got trains to catch
here.
Can I have some more food? Can we have dinner too?
Well, thank you very much.
Oh, this is good.
If you have other ideas, please feel free to email me, because, you know, I know we've had to put a lot in a little bit of
You know,
time.
before we all leave, I just, first of all, want to thank you all for coming down. Your leadership is really important. I think it was a very productive meeting, actually. Good dialogue. Want to highlight next meeting somewhere. Yeah, it's on the September 27th. So please reserve that, and I know there'll be lots of phone calls and discussion in between, and I hope you all found this productive. Will there be minutes that go out?
Yes, we will summarize the information and send minutes, and it'll really help guide us, I think, in terms of our next steps with environmental health. Mary Ann, I can connect with you and Wendell later on if you see some next steps in terms of working with our alliance that we can help move this forward.
Yeah.
And then I think, Danny, this has given us some great
Oh, yeah.
thoughts that are really going to help shape the direction for our working group, and we appreciate the thoughtful input that all of you have given. It's always, for me, just so much fun to connect with all of you and to hear your thoughts and to kind of advance